Hi, welcome to Conversations in Interventional Cardiology. My name is Holly Bauser-Heaton. I'm currently the Chief of Pediatric Cardiology at the University of Texas, Houston, and I'm honored today to represent SCAI and JSCAI Editor-in-Chief Alexandra Lansky. We're here today to discuss an important document published in JSCAI titled Economic Barriers to Interventional Cardiology Care for Adults and Children with Congenital Heart Disease and Potential Policy Solutions. I'm pleased to be joined today by an esteemed panel of SCAI leaders and experts. We have Lyndon Box, the Director of Cardiology at West Valley Medical Center, Frank Ng, Chief, Division of Cardiology at UC Davis Children's Hospital, and dear friend Dennis Kim, the Director of the Cardiac Catheterization Labs at Children's Healthcare of Atlanta. Thank you so much for joining, and I'm going to turn over to Dr. Box to start the conversation.
Great. Thanks, Holly. Excited to be here talking about this. And just start off quickly, I have no disclosures. And so this is the paper that the final title, The Economic Barriers to Interventional Cardiology Care for Adults and Children with Congenital Heart Disease. And on top of the barriers, we had talked about the potential policy solutions. And this was endorsed by not only SCAI, but also the process of endorsement, importantly, included the executive committee and SCAI leadership. So this was a document that really the entire society is behind. So the background of how this came to be, and particularly how I, as an adult interventional cardiologist that doesn't do any congenital work, got involved with this, there was really two groups working in SCAI that were dealing with these issues. One was the advocacy committee, which I was the chair of at the time, and then there was another group, the SCAI Congenital Interventional Coding and Billing Work Group, and there was a lot of overlap and crosstalk between those, but they weren't quite in sync with each other. They still functioned real separately, and a lot of conversations I was having, particularly with Frank, around this, it became very apparent that there were some really major challenges that was facing the interventional cardiologists that helped, patients with congenital heart disease that we weren't aware of, as adult cardiologists and as people that were in leadership positions in SCAI really weren't aware of. And Frank would come to me with these stories and I'd be like, that just can't be true. And it would turn out it was true, and it really was as bad as they were saying. So we felt like there needed to be something to try to, summarize what the problems were and really help define SCAI's position on how we can make those things better. So this is a really busy slide, and I think that actually makes a statement in and of itself because it covers the multifaceted problems that are facing the economic situation around congenital interventional care. So one of the biggest issues that comes up is that a lot of these patients have Medicaid. Medicaid has poor reimbursement. The other issues we identified was the process for valuation, which is how do we decide what you get paid for what you do, really doesn't work well for congenital procedures. Part of that has to do with the complexity and the variability. There's not a, quote, typical procedure that's done by an interventional pediatric or congenital adult cardiologist. There's a lot of variability in time, depends on, the critical illness of the patients that they come in with. And then the other thing is it's oftentimes limited to academic institutions, which really has a different financial structure than private institutions. And, we still see a situation in America where things are based on volume for payment, and, congenital care just doesn't really lend itself to volume-based payment. So all these things factor together, and it, in the end, penalizes our patients in addition to our colleagues. So this is a slide that I have to kind of walk you through a little bit, but it's makes a really powerful statement just about the differences in income, reimbursement or salary for our congenital colleagues versus adult colleagues. So the slide on the left is if you're, as I mentioned, a lot of these procedures are done in academic settings. So if this is the ratio or the percentage of income for a congenital operator versus an adult operator in academic centers. So this is kind of more of an apples to apples comparison. So you're looking, if you're an assistant professor, interventional congenital, you're going to be making around 55 to 60% of your adult colleagues. And when you get into the associate, you're going to be making 65 to 70%. And then you make full professor, the parity gets a little bit closer. But that's within academic institutions. And then if you take that to the slide on the left, or the graph on the left, and compare it to like all comers data for adult specialties of interventional cardiology, we're going to see that the interventional congenital is going to be making 35 to 40% as an assistant professor as their colleagues who are out in general practice. And I would say that the ratios may even be more extreme because those med-axiom numbers are kind of all comers, and a lot of times people say they're actually not as reflective of the true values out in the market. And again, you can just follow that slide across that even a full professor, very successful, established pediatric or adult congenital interventionalist is only going to be making 65% of what their counterparts are making in the adult world. So this is a real discrepancy that I think does have impact not only on the operators, but on the patients as well. So we didn't want to just have this document be a complaining session. So really the key thing was the end of the document where we go through what are some of the things we can do to make this better. And we took through the major problems that we identified. We talked about how it was going to be important to try to get better parity of payment with Medicaid on at least comparable to Medicare. Also, the valuation process. There's a lot of changes that really need to be made to help get a better value process for these types of procedures. Something that rewards things other than how efficiently you can do something simple, which is a way that a lot of the valuation seems to work. One of the problems we identified was that CMS sometimes would further reduce values when they were already approved by the RUC, which is the system that we currently use. So, how can we get better representation in that process? And ways that we can reward non-RVU based productivity. A lot of the work that the congenital operators do doesn't really fit into an RVU. And so how can we look at that? And then one of the other issues that we identified was that, the small market, there's not a lot of funding for device development. There's not incentives for that. So what are some ways we can improve those incentives? And I think that, looking at those as a whole, that's going to be ways that we can, try to establish a policy agenda for SCAI to try to improve these inequities across the system.
Well, Frank, I know that you have been really active and busy in this space for a long time, and our community and the society is really grateful for all of your persistent efforts, in this area. And, you've been in this congenital community a long time. And so what have been some of your observations in terms of history and in terms of recent change that we're seeing?
I have to say, first of all, I want to just say a shout out to Lyndon for actually initiating this. I thought that it was just so commendable that somebody who's not in our community take the lead and just push us to this point where we were able to get this together. I know we put a lot of work into this. I do think that over the years, I was not aware of all these disparities until probably the last 15 years. Up until then, we're in little silos. We're happy with doing what we're doing. We push the field. We do crazy things, using devices off-label. I wasn't smart enough or savvy enough to think ahead to say, are we really getting compensated for what we do? How is this our community? And I'm talking about including the patients. How does the financial system, the infrastructure, the reimbursements impact us? And again, just looking back at it, I just realized how little we've learned about it and how little we participated in the whole exercise, if you will. I mean, as the paper had said, Lyndon, you mentioned that of the RUC committee, there's only one pediatric person involved with that. And this committee makes all the major decisions about what codes are good and how to evaluate it. And I can't picture how one general pediatrician can really be an expert for all of the pediatric subspecialties in our field. And so, fortunately, Sergio Bertakian was able to be made a representative through SCAI a few years back, and he really pushed us for a few years. And I think that's ongoing. blown as every year there's a few more codes that were at least created for us. The one that was really truly mind blowing to me was that the septostomy, the balloon septostomy procedure that we've done since the 1980s. There was zero RVU tied to that because there was no expert in the meeting back in the 1990s that could actually speak to how much work it was, and so it was tabled for a later date. And for the last 20 years, or at least until 2018, there was no RVU tied to that. And of course, the work group that we organized worked hard to get some of these codes through. That was just like the best example I can think of how little we were involved, which resulted in our current status.
Yeah, I would agree, Frank. I mean, I think that the field of congenital interventional cardiology, both in children and in adults, is changing rapidly. We are going from the original balloon atrial septostomy in the 1960s now to doing complete NORD procedures in single ventricle patients in the cath lab. I don't think that anybody 15 years ago would have thought we'd be as aggressive with pulmonary vein stenosis in young children. And the use of stents, which goes back to the 1980s, really, is an area that has really taken tremendous leaps forward recently. And I think that the evolution of congenital interventional cardiology has certainly been rapid, but I think that payers as well as CMS has not necessarily kept up with those changes, and part of that is on us, I think, for not creating that awareness of just how complicated that things can be for these very fragile patients.
Yeah, to your point, if you think about even the add-on modifier 63 for kids 4 kilos and less, now that we're doing procedures on premature babies as small as 550 grams, there's a big difference between somebody that's 4 kilograms and 500 grams. And so therefore, some of the stress that is the intensity of the work involved with what we've done has just continued on as the neonatologists have been able to keep these preemies alive earlier and earlier in their prematurity, and then we get involved. So I think that we definitely have moving targets where the kinds of procedures we do are getting more complex, more intense, but yet we're not able to get involved on the coding side or the reimbursement side, or even for the payer side, for the work that we've done to keep pace with that. Lyndon, I have a question for you. I mean, as an adult interventionist, I don't know if you do any adult congenital heart disease, but I know that that's also another area that is sort of not keeping up. You have patients in pediatrics who've graduated to adulthood. Many have no longer covered by the pediatric types of Medicaid, so they go to the adult world. And oftentimes I hear from adult congenital heart patients where they don't know where to go because either there's just not enough adult congenital heart experts out in the field, or that they can't get the right insurance to cover some of their services, their needs. Does this come across your practice, or what do you think about that?
We definitely encounter that in practice. So my own experience has been, these patients have an extremely difficult time accessing care. One of the issues is that it's concentrated geographically. The care that's available. So I practice in Idaho, as was mentioned in the introduction. All of my patients are going to fly to go to get any type of congenital interventional procedures. This is where the economics really, I think, hits the adult community, is that if you look at the disparity in reimbursement and, the pay for somebody who's really passionate about doing complex adult interventions in congenital heart disease patients, they're going to have to give up a lot of money to do that compared to what they're going to make doing structural. And so there's that area is just completely underserved as far as the number of practitioners. So there's not enough practitioners, and they're all the ones that we do have are really concentrated to just not only just academic centers, but academic centers in major metropolitan areas. So it's a real difficulty and as we do address this in the paper, that it is very financially I think is one of the big factors.
I think that for patients who have private insurance, crossing state lines may not be as huge of a barrier. But in pediatrics, in particular for patients with congenital heart disease, over 50% of those patients are on governmental insurance. And because those are administered on a state-by-state level, as mentioned in the paper, that there are essentially 50 different hoops to have to jump through. And not only is it each state, but each state also has divided their Medicaid patients into various Medicaid HMOs, which are under different governance bodies by major insurance companies. One example I think is very interesting is that here in Georgia we have at least 4 different Medicaid HMOs besides the traditional state HMO or state Medicaid, and this idea of pre-authorization has really become a big nuisance, some of the state Medicaid HMOs have contracted with a clearinghouse whose previous experience was in orthopedic procedures. And so now we're dealing with a pre-authorization process with a company that really doesn't have any idea of congenital or adult heart disease for that matter. And, it's a huge energy sink and delays patient care and is very, very frustrating.
One of the hopes is that out of this, our goal was to set an agenda for advocacy work in the future. And getting into the more granular ideas, the idea of how can we come up with ways to make it easier to cross state lines for these Medicaid patients, because the added challenge of that is that the Medicaid policies are set within each state. So, how do you attack that? Do you go state by state, or do you try to do something at a national level? So this is actually an active issue that SCAI is working on.
And to your point, Lyndon, I remember Holly did write a paper on similar topic on disparities, where I recall the discussion on how many actual congenital heart programs there are across the state, and how there are several states that don't even have a program in the entire state. So therefore, a lot of these patients have to travel far and wide to get care. And so I can see how there's so many compounding factors that is causing these issues, and the availability of care is impacted just from a lot of the things that was discussed on the paper. Holly, do you remember that part of the paper? I was struck by how many states did not have actual program.
I do. I think you all bring up an important point. Sometimes we talk about reimbursements, and oftentimes it's focused on the physician and what's coming back to them in the hospital. But I also think about, as you were alluding to, the effects on our patients. In addition to the ACHD community, I think in general, the congenital community is at a disservice because of these reimbursement rates also for development of devices. And I know it's touched upon in the paper, we already are dealing with what I would consider orphan disease, in the sense that, these things are quite rare. And for us to have such low reimbursement rates, we're not going to have the buy-in from industry to help us create these devices to help. So in addition to the concern with ACHD and the development there, I think in general, we are providing a disservice to our patients by maybe not advocating like we could have and should have going forward. Again, not from a physician standpoint, but also for the congenital community at large. I think when we talk about any disparities, yes, we think about traditional disparities, but in the congenital community, I think we do have to think about the low numbers that we have, but the complexity, the solutions aren't easy, and we need help financially and from industry to make those solutions a reality.
I would add one more stakeholder to this, and that's the regulatory agencies, right? I mean, yes, on the industry side, there is low ROI, return on investment for our products. But traditionally, the FDA has also been pretty rigorous in their science in terms of getting something approved. But I know that in the last probably 10 years, they've learned that we are truly orphan disease givers. And so I think that there has been a change in the FDA to change some of the methodologies, if you will, to account for low volume, so that the statistics aren't based on huge volumes that you see in the adult world. And I have noticed some changes in guidelines and how devices can get approved via new pathways. So at least I think there is some movement. And again, I can't help but think about, when this paper is published, how will this move on to the next stage? I think that this will serve as a good reference paper for future efforts. But certainly I think that this can be used for argument in many different venues, including with industry, with the regulatory agencies, and just within our society, and how we can mobilize and advocate for our patients.
Yeah, Frank, I wanted to add, to that. I think our hope was that this would be educational for our members. A lot of us, I became aware of this through my work in the advocacy committee. The adult community is we're oblivious, or I'm no longer am, but most of us, at least the majority are. And the other thing, I know a lot of our audience listening to this are going to be congenital, operators. I really want to emphasize how important it is that this was endorsed by SCAI and by the executive committee. This is something that I think historically the congenital community at times has not necessarily felt as part of, at least that's the sentiment that I've gotten sometimes from talking to people. And I think that's definitely changed. And this is just emblematic of that, that the executive committee signed off on this and said, this is our policy regarding, economics issues around congenital. And there's things in here that, you could look at it and say might even be, in their best interest not to support, but, from a self-preserving point of view. But I think, the unanimous support we got from the executive committee really spoke to how much SCAI values the work that's done in the congenital space.
If we could maybe just take away a learning point for those who are listening to this, if you're a congenitalist sitting on the other side, digging into this paper, what's one action item that you think folks could take away that would move things forward?
Yeah, for me, it's actually just getting engaged in this. I spent some time in academics, and I think so many of us, even aren't in academics, early career, whatever, we put our head in the sand around the financial issues, and we don't really want to hear about it. We don't want to be engaged in it. We kind of use the excuse of, I just want to take care of my patients. And I think you really brought up a great point in your paper that you did previously, illustrated this very eloquently, is the fact that this is a patient care issue. And we allude to some of the data in the document about how this actually leads to worse outcomes in our patients. They do not do as well because the financial space around congenital care is not really conducive to delivering good care. And so I think that would be the one takeaway that I would give is, get in the fight, get engaged. You don't have to be an expert on policy, but this is a great starting point, is just take this paper, just look at the figures, read through the headlines. And I think that would be the one takeaway I would give, that somebody who's totally new in this area, you're not passionate about advocacy, but you want to do something, then that would be my one takeaway point.
I think when I thought about your question, and I'm an old dog in this field at this point, and so I think that the one takeaway point is how do we use this data to push on forward? We've made some strides in the last 5-10 years, but there's so much, we're so far behind that there's still so much work to do. How do we mobilize and advocate among the politicians, insurers, and regulatory agencies to move this along? I know that this is not unique to the US. This happens at other countries as well. So, even goes beyond the borders in terms of this orphan disease. I hear this from the physicians in Asian countries, in the European countries. So this is not unique to the US. Maybe the reimbursement models are different, but the idea that this is an orphan disease that most people aren't aware of and do not understand the complexity of the work that we do and the care that is required for these patients, that definitely needs more advocacy on our part. And I agree with you, Lyndon. I thank SCAI for really sponsoring this paper, and hopefully we can keep marching forward.
Yeah, my takeaway from all of this is that this is obviously an important area, but I think that my takeaway is that I cannot think of another professional organization that would represent congenital interventional cardiologists in a similar way that SCAI does. I think that the SCAI leadership, including Lyndon and the executive committee, have made a commitment to the congenital community. I think that the advocacy arm of SCAI is much more powerful than in any of the other organizations that we are part of, and I think that we can truly consider this organization to be our professional home.
Well, thank you all for taking the time to be with us and talk about this important issue. And we'll be looking forward to the interventional community and the congenital space getting involved.